Okay, live stream is up. Sergeants, would you begin your recordings?
PC recording has started.
Cloud is on the way.
Good morning and welcome to today's New York City Council hearing on mental health, disabilities, and addiction, joint with the Committee on State and Federal Legislation. At this time, will all panelists please turn on your videos for verification purposes.
Sergeant Bradley, can I stop you for one moment? We are in gallery mode on Zoom. If we can have that switch, please.
No problem. To minimize disruption, please place electronic devices on vibrate or on silent mode. If you wish to submit testimony, you may do so at testimony@council.nyc.gov. Again, that is testimony@council.nyc.gov. Thank you for your cooperation. Chairs, we may begin.
Okay, so I guess this is the part where I gavel, huh? I just want to welcome all of you. Good morning for this very exciting topic that I know that all of us are very invested in. I'm actually excited to be joined also by my fellow colleague, Sean Abreu, Councilmember Abreu, who is the chair of the Committee on State and Federal Legislation, which is going to be an important piece of today's hearing, which is coordination of the state and city and the provision of mental health services. And also, I would like to welcome our fellow council member, Chi Osei. We will also be hearing introduction number 0056-2022, relating to establishing a nightlife opioid antagonist program. I'd also like to acknowledge the members of the committee that are present here with us today. I see we have Councilmember Palladino, as well as Councilmember Shahana Hanif, and also our Majority Leader Powers is here with us. Councilmember Marte, thank you all for joining and for being with us this morning. If I missed anyone, I see Councilmember Caban is also here, as well as Councilmember Botcher. Thank you so much to everyone for joining us today. And as we know, I'll try to make my opening statement very brief, but as we know, there is a huge mental health crisis that we're facing in the city today. And there's a desperate need for behavioral health services, but we're facing an endless barrier to accessing this care. And this is particularly true for lower income communities and communities of color. Provision of mental health services occurs through a very complicated web of private providers, insurers intersecting with federal, state, and local entities, funding, and regulations. And while in New York, I believe we are resource rich compared to many other states and cities, the intersection of governmental entities and regulations can create bureaucratic and logistical barriers in the provision of mental health services. And for myself as a former mental health care provider, I can attest to the fact that it is often not the lack of resources that prevents communities from receiving care, but instead it is this intricate balance and dance that we have between bureaucracy, lack of governmental coordination, and also a lot of strict regulations, which we know are there for good reason, but oftentimes can be what prevents individuals and communities from accessing care they need so desperately. So just to provide a couple examples, the minimum standard of inpatient care is often marked as 50 psychiatric beds per 100,000 people. But as of 2018, New York actually has failed to meet this standard, and it was at 16.3 beds for 100,000 people capacity. So again, it should be at 50, and in 2018 it was at 16.3, which is less than 1/3 of the minimum standard. And I think the answer to this is complicated in terms of how we ended up here, but one of the reasons I think is that since the 1960s, the federal government actually has placed a prohibition on fully paying for state inpatient psych services. So to overcome that and receive full funding, the states must apply for a waiver. I believe New York State has not done that, but instead, as we know, the mayor and governor have vowed to restore several hundred psych beds, which is great, especially since we lost a lot during the pandemic. and to commit more funding to psych services. But this complicated relationship between the Fed, state, and city actors, the funding regulations is part of the reason why it's so difficult for us to access these services. Another frustrating example, which I personally know all too well, is that the New York state reimbursement and parity rates for mental health services is extremely and embarrassing low. So in a national survey of state efforts to ensure parity when it comes to behavioral health insurance benefits, New York received a failing grade. And on a city-specific level, the city employee insurance provider, which is Emblem GHI, was found through 4 attorney general investigations between 2009 and 2018 to have not updated its reimbursement rates since they were set in 1983. And so what you see here, and what I saw in the own clinic that I ran in my previous nonprofit, is that the reimbursement rates are low. So what ends up happening is, realistically, a lot of these outpatient clinics, they need to pay bills, they need to pay their staff, they need to pay rent, they need to keep their lights on. And so what's happening is that we're not providing access to patients that need the most care, but it's based on our ability to pay. And so it's not outcomes driven or who needs care, but it's really simply, so a lot of times what happens is that because Medicaid, for example, reimburses more, a lot of clinics tend to get more, about, I would say the ratio is safely 60% Medicaid in order to cover your expenses and costs. So as a city, I think this is where we as city council members can push the city insurance payers to actually pay higher rates for mental health services and actually include more of that in the insurance plans. So I think that is something that we can do, and I look forward to working on that more. And we need to do a better job actually negotiating better reimbursement rates for a lot of the folks that they insure and cover. And one final example that I'll just go over is that New York State allows a licensed clinical social worker, LCSW, to be reimbursed if the insurance group requests it. But in New York City, the city employees insurer, which is again Emblem, requires additional training known as an R designation. So you can have an LCSW-R next to your degree, which, yes, it does provide more oversight, more hours, more training. But it's an additional 36 months and 2,400 hours of direct client contact post your LCSW, plus additional fees, paperwork, and clinical supervision. So although I understand the need and requirement to have more supervision, oversight, and training, given the fact that we're in a mental health crisis, I think that it is important for the city to figure out a way to not impose additional barriers to practice in New York City, but actually, providing ways to access clinicians from actually getting their certifications in an easier way. So while these regulatory and bureaucratic inconsistencies and barriers are very frustrating, I'm also confident that we as a city and a state can come up with solutions that make sense to make mental health more accessible. Whether we're coordinating together as city through Department of Health and Mental Hygiene, Health and Hospitals, or through the newly created Mayor's Office of Community Mental Health, or whether we are coordinating with our colleagues in the state, these are problems we must address and ultimately fix. And even just yesterday, I was speaking on a mental health panel through city and state with the OMH commissioner at the state level, Ann Sullivan. She's great, she's smart, she understands all the issues. And I think there's a real opportunity for us to coordinate on both a city and a state level to make sure that the funding is there, but also that the regulations compliance meets our need in this recovery time post-pandemic. Because I think we have a tremendous opportunity to make improvements here, especially through our partners. I see Dr. McCrae here from DOHMH, thank you for being here, as well as Dr. Barron from Health and Hospitals, who is the only safety net hospital system in New York, which is amazing. And so I'm excited to hear from you guys today, because we need you both obviously as partners in this, and we can't do it alone. So I just want to thank my colleagues as well as my staff, John Wani, who's our legislative budget director, as well as Chief of Staff Asher Zlotnick, the council committee staff, Assistant Deputy Director Sarah Liss, and Legislative Policy Analyst Christy Dwyer, Finance Analyst Lauren Hunt, for making today's hearing possible. So thank you all so much. And with that, I will turn it over to my colleague, Chair Abreu, for his opening remarks.
Thank you, Chair Lee, and good afternoon. My name is Sean Abreu, and I am the chair of the Committee on State and Federal Legislation. Thank you for joining our virtual hearing today on the coordination of the state and city in the provision of mental health services. Before we begin, I would like to thank Chair Lee for the opportunity to work together on this incredibly important topic. Over the course of the last 2 years, we've paid very close attention to the physical aspects of our healthcare due to the serious circumstances of the pandemic. Even though the physical health of New Yorkers should always remain a priority, it is crucial to remember that mental health is just as important. Adequate care and access to mental health providers is difficult to achieve without proper coordination between the city and state. Albany has been working to make strides in the mental health field, and it is imperative that we look at their work to see how the city can best collaborate with the state to provide care and services to New Yorkers. Recently, the state has adopted a new rule that permits licensed applicants with doctoral degrees in psychology to qualify for New York's education requirements for licensure, helping to streamline a lengthy application process in an effort to increase access to mental health providers. Additionally, there is legislation pending in Albany on this subject. A5540, sponsored by Assemblyman Palmisano, is a bill that would allow the state of New York to become a member of the Interstate Medical Licensure Compact. This would allow physicians to become licensed in multiple participating states, thereby increasing the number of mental health service providers that can provide counseling and care to New York patients. Furthermore, the state is also considering a bill introduced by Senator Brad Hoyle. If passed, S8422 would authorize the payment of medical assistance funds for long-term stays in large residential mental health institutions. Efforts like these will greatly impact all New Yorkers and ensure growth in accessibility and options for New Yorkers looking to prioritize their mental health. I'd like to thank committee staff, Jay Street, Ganapathy, Senior Counsel to Committee, William Diori, Policy Analyst, Hector Herman, Financial Analyst. I would also like to thank my staff, Jaleesa Quigley. I will now turn it over to the committee counsel. Thank you.
Sorry, just wanted to acknowledge, I believe we've also been joined by Councilmember Gutierrez as well as Councilmember Williams. So I just wanted to say hello to both of you as well. And actually, I wanted to turn it over to Councilmember Osei, if you will, to deliver an opening statement. So Councilmember Osei, feel free. Are you allowed to unmute? Can you unmute?
There we go. Thank you so much, Chair Lee and Chair Abreu. Just watching your leadership is inspiring, especially on an issue so prevalent in our city and state here today. The number of overdose death rates in New York have skyrocketed since the onset of the pandemic. According to the Department of Health and Mental Hygiene, there were over 2,000 overdose deaths in the city in 2020, an increase of nearly 600 deaths from 2019. These deaths are also disproportionately impacting Black neighborhoods, with death rates in central Brooklyn, Harlem, and the South Bronx exceeding the citywide rate. Brooklyn alone lost 371 lives to overdose last year. The culprits behind these deaths are usually substances laced with dangerous opioids like fentanyl, a highly potent synthetic opioid with 50 times the strength of heroin and 100 times the strength of morphine. But these deaths are preventable. Every overdose is preventable, and these lives can be saved. Access to opioid antagonists, such as Naloxone, can reverse an overdose and save a life. We have a responsibility as representatives and leaders to expand access to these vital medications to New Yorkers who need them most. As a young person who formerly worked in the nightlife industry, I know that our patrons who frequent our bars, clubs, and other nightlife venues are impacted by fentanyl-related overdoses and the need to combat them. Currently, the Department of Health and Mental Hygiene has a program called Narcan Behind Every Bar, which is a program that provides bars and other nightlife establishments with naloxone, I'm proud to be a sponsor of Introduction 0056 because we need to codify this program to ensure that the Department of Health and Mental Hygiene can continue to provide this resource for our city, and to ensure that we, as the City Council, have reporting information that will allow us to measure the program's rate of success and where there are gaps that need to be addressed. We have the tools to blunt this crisis. Let's use them. And I would like to thank my co-prime sponsor, Majority Leader Powers, as well as the chairs for allowing me to speak this morning.
Thank you so much, Councilmember Osei. And I'm going to go a little bit out of order because I know that Majority Leader Powers is also, as you mentioned, a co-prime sponsor. So just wanted to give you the opportunity to say a few words as well.
Thank you. Thank you, Chair Lee. Thank you, Chair Abreu. And thanks for giving me just a minute. I won't take too much time, but thanks for having me. First of all, I just want to commend my colleague, Councilmember Osei, for introducing this bill and getting up to 36 sponsors so quickly into session, Democrats and Republicans on the bill. And it's an impressive feat to get there so quickly, but it's because it's a life-saving measure that is a kind of the intersection. It's a common sense intersection point when you're talking about trying to do harm reduction here, to make sure that people that are in nightlife establishments, where we have to be clear about what people do in nightlife establishments, which is people sometimes do drugs, that there is an opportunity to save their lives there. And so I think this is a really kind of common sense piece of legislation, but with a really, really good end goal of to save people's lives and to be in places where it's most needed and necessary. So I hope that other colleagues will consider signing on to this bill as well. It's something that Councilmember Osei and I discussed even before he got into the City Council and decided to work on this bill together, both being people that care about finding these intervention points and also, having ties to the nightlife industry here and knowing that they would be good partners in helping us to combat overdoses. So I just ask people to take a look at the bill and please sign on, and very happy that we're getting a hearing on this today, and very big congratulations to Councilor Osei for moving so quickly on a really important life-saving measure. Thanks so much.
Yes, thank you to you both. And then I will now turn it over to our moderator, Committee Counsel Jayshree Ganapathy, to go over some procedural items.
Thank you, Chair Lee. I am Jayshree Ganapathy, Committee Counsel to the Committee on State and Federal Legislation, and I will be moderating this hearing. Before we begin, I would like to remind everyone that you will be muted until you are called on to testify, at which point you will be unmuted by the host. During the hearing, I will be calling panelists to testify. Please listen for your name to be called, as I will be periodically announcing who the next panelists will be. At this hearing, we will first be inviting testimony from the Health and Hospitals Corporation, the Department of Health and Mental Hygiene, and then from members of the public. During the hearing, if council members would like to ask a question of the administration or of a specific panelist, please use the Zoom raise hand function and I will call on you in order. For all panelists, when called to testify, please state your name and the organization you represent, if any. We will now call representatives of the administration to testify. We will be hearing from Dr. Charles Barron, Deputy Chief Medical Officer of the Office of Behavioral Health at New York City Health and Hospitals Corporation, and Michael T. McRae, PhD, Acting Executive Deputy Commissioner of Mental Hygiene at the Department of Health and Mental Hygiene. We will also be joined for questions by Dr. Rebecca Lynn Walton, Senior Assistant Vice President at the Office of Behavioral Health at New York City Health and Hospitals Corporation. At this time, I will administer the affirmation. Panelists, please raise your right hands. Do you affirm to tell the truth, the whole truth, and nothing but the truth before this committee and respond honestly to council member questions? Dr. Barron?
I do.
Dr. McRae?
I do.
Senior Assistant Vice President Lynn Walton?
I do.
Thank you. At this time, I'd like to invite Dr. Barron to present their testimony.
Thank you. Good morning, Chairperson Lee, Chairperson Abreu, and members of the Committee on Mental Health, Disabilities, and Addiction. and the Committee on State and Federal Legislation. I am Dr. Charles Barron, the Deputy Chief Medical Officer of the Office of Behavioral Health and Medical and Professional Affairs at New York City Health and Hospitals. I am joined this morning by Dr. Rebecca Lynn Walton, Senior Assistant Vice President in the Office of Behavioral Health at Health and Hospitals. I'm happy to testify to you today to discuss the coordination of state and city in the provision of mental health and behavioral health services at health and hospitals. Health and Hospitals is the main provider of behavioral health and inpatient psychiatric care services in New York City, currently operating one of the largest and most robust continuums of mental health and substance use services in the country. All of our mental health services are licensed and regulated by New York State. Our mental health programs, which include psychiatric emergency, inpatient and outpatient clinics, are licensed and regulated by the New York State Office of Mental Health. Our substance use in medical and other settings, including the emergency departments, inpatient medicine, outpatient substance use, and methadone programs, are all licensed and regulated by the New York State Office of Addiction Services and Supports. And as hospitals, we are also licensed and regulated by New York State Department of Health and are subject to Joint Commission review. As such, we work with the state closely in the provision of all of our behavioral health services. Health and Hospitals is in regular communication and coordination with the Office of Mental Health, as well as city agency partners like the Department of Health and Mental Hygiene, the Department of Homeless Services, the New York City Police Department, and the Mayor's Office of Community Mental Health, and many others, to support homeless patients with behavioral health needs. This includes the most recent Subway Safety Plan and the Be Heard programs. When COVID-19 first saw its case in New York City in March of 2020, Health and Hospitals was at the forefront, responding to the needs of its patients and the city overall. Amidst unprecedented circumstances, Health and Hospitals kept its doors open so that New Yorkers could safely access care. We utilized all modalities, including in-person, telephonic, video calls, home visits, and mobile crisis outreach to provide care. Working hand in hand with the Department of Health and Mental Hygiene, the Office of Community Health, Office of Mental Health, and OASIS, the Health and Hospitals ensured coordination of all available behavioral health beds across all hospitals. To accommodate the surge in critical COVID-19 patients, Health and Hospitals worked as one system to safely transfer behavioral health patients to other facilities that had capacity, even standing up COVID-positive psychiatric unit in several of our hospitals. COVID led to necessary relaxing of certain regulatory barriers to care that have greatly improved our ability to receive and retain patients in our care. When the pandemic began, telemental health services and sessions rolled out in psychiatry, substance use services, the Family Justice Centers for Domestic Violence, addiction consult teams for both medical emergency departments and inpatient medicine, and mobile treatment in both mobile crisis teams and assertive community treatment teams. To help make this possible, Health and Hospital distributed iPads to inpatient and emergency department behavioral health consult services. To date, Health and Hospitals has completed 520,000 behavioral health sessions telephonically and virtually. Other initiatives launched during the pandemic include the virtual buprenorphine clinic, created to provide same-day buprenorphine access to existing and to new patients. We also partnered with the state, the Department of Health and Mental Hygiene, and OASIS to provide methadone delivery to patients on quarantine at hotels and in their homes, or to stable patients who were at high risk of complications from COVID, for whom it was not safe to attend in-person sessions. For New Yorkers who required quarantine at a Taste and Trust hotel, we provided access to behavioral health services. Once COVID-19 vaccination outreach began, the Test and Trace launched the Street Health Outreach and Wellness mobile units, or better known as show vans. We also began providing free mental health and substance use screenings on these units, as well as linking people to ongoing care, either virtually or in person. With the introduction of behavioral health telehealth services, Health in Hospitals has seen significant positive effects. Virtual access to mental health and substance use services, especially being able to initiate buprenorphine via virtual care, has meant patients have access to care, including detox support, right in the safety of their homes. Virtual express care helps us access urgent cases and reduce unnecessary emergency department visits. Tele and video therapy have enabled patients to see clinicians safely and more frequently when needed, and help us retain patients in treatment through lockdown and beyond. Methadone delivery to patients isolating during COVID was greatly supported patients. We look forward to building on the success of these evolved services to continue to meet New Yorkers where they are and to provide care they need. In October of 2021, Health in Hospitals received $1.8 million award from OASIS to expand services to opioid and stimulant use in underserved community of the Bronx, Manhattan, and Queens. The funding helps coordinate emergency department substance use access, consults for addiction treatment and care in hospitals, or better known for us as CATCH programs, outpatient services, and virtual access to substance use care and bridge between substance use disorders and psychiatry for patients with co-occurring mental health and substance use diagnoses. However, there are a lot of areas within the behavioral health system nationwide that need improvement. The federal government continues to regulate methadone in a manner that is overly restrictive for patients. Patients must receive medications in heavily regulated specialized clinics. The state is currently rightly advocating to allow methadone to be dispensed in traditional outpatient substance use clinics, which exist in greater numbers, and to make this life-saving medication available to pharmacies. This change will allow patients to receive their medications when and how it is convenient, and to receive treatment as a support rather than a condition tied to receiving life-saving medication. We support this effort to remove barriers to easily access medication and treatment. Another of the better known issues is the parity for behavioral health billing and the inability to bill for social work and primary care settings. As Health in Hospitals moves to implement behavioral health support throughout the system, including right in primary care settings, having these licensed clinicians able to provide and bill for services is key to patient care and financial sustainability. In order to overcome these barriers, healthcare providers need increased funding for new models of care and care provision for uninsured, advocates for stakeholders, including elected officials, to reduce regulations that increase barriers to care, and expansion to key existing safety net services, especially for special populations. Health in Hospitals has a long history of taking care of the most vulnerable New Yorkers and will continue to do so. We look forward to continuing to partner with government and key stakeholders to forge solutions. I thank your committee for your attention to this important topic, and we are happy to answer questions that you may have. Thank you.
Thank you, Dr. Barron. We would just like to now invite Dr. McRae to testify.
Alrighty. Good morning, chairs Lee and Abreu, and members of the committees on mental health, disabilities, and addiction, and state and federal legislation. I'm Dr. Michael McRae, Acting Executive Deputy Commissioner of the Division of Mental Hygiene at the New York City Department of Health and Mental Hygiene. On behalf of Commissioner Vassan, thank you for the opportunity to testify today on proposed Introduction 56. First, I want to thank Majority Leader Powers and Council Members Osei for championing harm reduction approaches to substance use and overdose. We appreciate you bringing attention to this issue and helping to dismantle the stigma around substance use and people who use drugs. Before discussing the bill, I'd like to take a moment to acknowledge that New York City is facing an overdose crisis. 2020 was the deadliest year on record for drug overdoses, both in New York City and nationally. More than 2,000 New Yorkers died of a drug overdose in 2020. This trend continued into the first 2 quarters of 2021, when there were 1,233 overdose deaths, compared to 956 or 65 overdose deaths during the same period in 2020. This equates to 1 person dying of an overdose every 4 hours in New York City. In response, the health department has strengthened our kind of a multi-pronged harm reduction approach to addressing overdose. We continue to work closely with syringe service providers across the city, expand access to effective substance use disorder treatment, and support the implementation of new evidence-based strategies to prevent overdose, including the overdose prevention centers. The health department has also ramped up efforts to address the involvement of fentanyl in overdose deaths through public awareness campaigns and fentanyl test strip distribution. Naloxone distribution is a central piece of the health department's strategy to curb the overdose epidemic. Naloxone is a life-saving drug that can reverse an overdose, and our data shows that most overdoses occur in someone's home. And we work to equip people who use drugs and their loved ones with naloxone to prevent overdose deaths. We aim to make naloxone and other safer use supplies widely available across a variety of community settings, including nightlife settings like bars and clubs. Since 2018, we have worked closely with the Office of Nightlife at the Mayor's Office of Media and Entertainment to provide trainings and promote availability of naloxone at nightlife establishments. In 2018, with the help of from the Office of Nightlife, we initiated our Using Cocaine's initiative, through which we conducted direct outreach to nightlife venues on the Lower East Side to educate staff about the presence of fentanyl and cocaine and the risk of overdose, train staff and patrons to administer naloxone and respond to overdoses, and provide venues with naloxone kits, coasters, and posters with overdose prevention messaging. The initiative was well received by nightlife staff, patrons, community partners, and was expanded to North Brooklyn in 2019. In 2021, the health department partnered with the Office of Nightlife to hold a special virtual naloxone training for those who work in the nightlife industry as part of their launch of their Narcan Behind Every Bar public awareness campaign. Over 250 naloxone kits were mailed to individuals following that training. And importantly, an employee of a nightlife establishment can currently reach out to the health department or any opioid overdose prevention program to get trained in overdose response and receive free naloxone kits. The Office of Nightlife promotes these trainings through the ongoing Narcan Behind Every Bar campaign with regular webinars, social media posts, and other communications with thousands of venues they work with, all to ensure nightlife establishments are aware of this opportunity and can join as partners in our collective efforts to combat the opioid crisis. For everyone here and everyone listening, I want to be clear, naloxone saves lives. We encourage all New Yorkers who use drugs or who know someone who is at risk of an overdose to get trained in overdose response and have naloxone available. You can visit the naloxone page of our website or call 311 to learn more about where to find naloxone or take one of our virtual trainings to receive a free kit in the mail. We appreciate our partner community-based organizations and the council for their help in promoting these trainings and increasing access to naloxone. I will now turn to proposed introduction 56, which would establish a nightlife opioid antagonist program at the health department and make naloxone related trainings and resources available free of charge to nightlife establishments. The health department supports the goal of this legislation to expand access to opioid antagonists and ensure continued coordination with the Office of Nightlife to prevent overdoses in nightclub establishments or nightlife establishments. We look forward to working with council on the bill to ensure our shared goals are achieved, and that New Yorkers continue to have access to this vital and life-saving resource in these settings. Thank you for your continued partnership and support for the health and well-being of all New Yorkers. I'm happy to take your questions.
Thank you. I will now turn it over to questions from Chair Lee. Panelists, please stay unmuted if possible during this question and answer period. And I would also just like to acknowledge we have been joined by Council Members De La Rosa and Minority Leader Borelli.
And also Councilmember Mealy, I noticed, also joined as well. So I didn't want to forget that. Thank you so much. So I'll just dive right into the questions. Thank you again, both Dr. McCrae as well as Dr. Barron for being here with us, as well as Dr. Rebecca Lynn Moulton. I am huge fans, again, as I said before, of the work that you guys do at H&H, and just wanted to thank you both again. So, you know, one of the common themes I think that we've been hearing that's sort of a barrier to accessing services, or when you look at the whole mental health continuum of services and care, is really the coordination of services between especially the agencies and the nonprofit organizations and the CBOs on the ground. So I just wanted to know, and I know some of the answers to this just from my own experiences, but if you could, for my colleagues as well, explain what H&H as well as DOHMH is doing to coordinate the mental health, coordinate with mental health providers and organizations in the neighborhoods that they're located in, which I know is sometimes difficult because of where the hospitals are situated, but if you could explain what the outreach efforts are and coordination with different organizations, that'd be great.
Okay, I guess let me go first. Thank you for that question. I think that H&H has a long history of working with our community-based partners. While we are certainly the largest acute care and also outpatient in our city, we also very much depend on our community-based partners and work closely with them for the care of our patients. I think one of those barriers has been, like you say, the communication and coordination between them. One of the things that has recently happened and really improved that is the establishment of our system-wide electronic medical record. One that allows all of our hospitals and clinics and anything associated with health and hospitals to have access to patient records if they go to multiple facilities or multiple clinics. In addition to that, with patient consent, if they are also attending a community-based clinic or a community-based program, we can provide access to that particular organization. That's allowed a lot of cross-agency, cross-program communication and providing a more comprehensive and proactive approach to treatment. I don't know if Michael or others have comments.
Thank you. No, sorry, I was trying to unmute here. No, so we are, we're committed, obviously, to ensuring New Yorkers have access to high quality mental health services. We work very closely with our sister agencies across the city, as well as with the state to really help, think about our ways to coordinate, make sure we are coordinated in our thinking around folks that we are seeing. We coordinate regularly around planning, oversight, implementation, improvement around our programs with the state, our state agencies, OMH, OASAS, OPWDD, around specific programs. We're in regular communication with our state partners and our city sister agencies. Dr. Barron mentioned psyches. While the OHMH does not have a large, we're not a large service provider. Our city contracted providers do have access to psyches, and we're constantly in communication with OMH around improving ways that psyches can help inform clinical decision making.
Okay, and I guess so. Actually, let me ask this question first. Also, in terms of your agencies, how is it with coordinating and do you guys play a role in coordination with OCMH so far, which is the new Mayor's Office of Community Mental Health?
Yes, Health and Hospitals is in very close coordination with the Office of Community Mental Health. And many of our programs, example, the Be Heard program, the Subway Outreach program, the Mental Health Service Corps, and multiple others. So we work very closely with them on a variety of programs that serve New Yorkers and continue to try to expand access for all New Yorkers in any community.
Okay. And just because the way my brain works is I'm thinking of this as like an org chart. So if I'm understanding it correctly, so is it like, for example, take the Be Heard program. I know technically it's under OCMH, but is it that they're overseeing it and H&H is administering it? Is that the relationship there? Or if you could go a little bit more.
I mean, it certainly is under the OCMH is overseeing a lot of this. It's a collaboration. It's a really wonderful collaboration between OCMH, H&H, and FDNY, and the DOHMH. They're all of us are coordinating on this and have different parts of that. But OCMH is sort of overseeing that and helping to sort of facilitate coordination. And then we are the ones providing the clinical support. Social workers.
Right. And you're in contact with which staff, the acting director, correct? Or is
yes.
It? Okay.
Yes.
And then also in terms of the outreach and efforts to let's just say, if you could give us a list, it doesn't have to be right now, but do you have a list of the Article 31s that are in the communities, as well as some of the mental health services like NAMI's peer-to-peer, family-to-family supportive services that actually do provide some of the supportive services? I just wanted to know if there was, the range of different types of services that you have connections with through H&H.
Yeah, I'll give you an overview, but I'll supply you later a list of more specifics. But yes, we have each of our acute care hospitals has Article 31s and Article 32. That's both mental health and substance use clinics and programs in theirs. In addition to that, in the communities, we have a number of Article 31s throughout the city that provide these particular behavioral health services. Yes. We do also provide virtual with our establishment of our Express Care Clinic for behavioral health. This has certainly expanded access and outreach to anybody in any part of the city. Can access services and either could receive services there or be also connected to some close Article 31 or 32 to them. And we do outreach and work with NAMI and other organizations such as NAMI or FAMI, and use them quite effectively. They do meet in some of our hospitals and some of our programs. Yes.
Oh, awesome. And I'm guessing there's also a relationship with the FQHCs, or not as much with the FQHCs?
Yes. We do have Article 31s in the FQHCs. Yes.
Okay.
And I can give you a list of where those are.
Okay, awesome. And I know it's challenging because especially in a city like New York, the language barriers, and this is something that I think maybe we could partner with on the state, is that, the language barriers, cultural barriers are oftentimes a huge issue in terms of reaching the hard to reach communities, so to speak. And so, if there are ideas or ways that you can think of, or if you have done outreach and can speak to that in terms of those hard to reach communities, because I feel like those are the ones oftentimes that are totally not even in this equation at all. And so if you could also just speak to some of the groups that you're working with on that side as well. Sure.
This has been a longstanding issue that I've been involved with in some of my previous background with H&H. But we do serve the most diverse communities, certainly in the United States, and so H&H has long had a history of trying to, in each of our communities, recruit staff who are native speakers, understand the culture, really are able to do that and match our staff with the patients that we're serving in the communities. In addition to that, we offer through our human resources and education office, we really specialize in looking at cultural sensitivity to make sure that everyone has the knowledge and ability to do that. We also partner again with the state in looking at trying to outreach to various communities. There are certainly some very hard to reach communities within New York City, and we're always striving to try to find ways of meeting those needs of both language and culture to provide the appropriate level of service for them.
Yeah. And I know that the H&H hospital that we worked closely with at Elmhurst that has a very, very diverse staff with different language needs, which I think is great.
That was my previous hospital.
Oh, yeah. Nice. And speaking of because I think one of the biggest issues we're hearing across the board, which I'm sure you're finding as well, is the workforce issues, because there's such a shortage of people. There's burnout, not enough pay in the, for mental health providers. And so how are you dealing and coping with the work shortages, either for DOH both as well as H&H? Because I know that I've heard that there have been staff vacancy rates of upwards to 30 to 40%. And so obviously this is very concerning when we're at a crisis in the city where we need to meet these needs. And so I just wanted to know if you could speak to how you're dealing with the work shortages, as well as what you think some of the potential solutions could be, or barriers either way.
Yes, there is a national shortage of behavioral health clinicians and people that work and specialize in this particular area of healthcare. H&H is certainly one of those that are doing that, although I think we have more resources sometimes than other areas of the country. We're constantly recruiting, looking at ways of having people doing. Right now, we are really involved in some active different recruitment efforts. We're looking at establishing new and different models of care that involve other disciplines other than physicians, nurse practitioners, physician's assistants, social workers, psychologists, LCATs, other people. So we really have been developing new models of care that allow us to use other clinicians and other specialists to provide care that would increase access to that. We're also looking at other incentives that try to help to recruit and retain mental health staff into our various facilities. And we're beginning to do also a lot of outreach to schools and related areas to really begin to provide education and hopefully to help people be much more interested in becoming part of the behavioral health workforce in the future.
That's awesome. Yeah, I feel like we need to start young and getting them thinking about these careers at a very young age. So that's great. So switching gears a little bit, I know that there are some neighborhoods where there are still challenges to accessing mental health care. I think there's 3 neighborhoods in particular that I know is the lowest connection to healthcare, which is Kingsbridge, Borough Park, and Northeast Bronx, where only 20% of those with mental health care needs receive the actual treatment that they need. And so just wanted to hear from you what was, what is being done to target those particular neighborhoods. Has there been any sort of additional resources being poured into those areas and outreach?
Well, physically, we're limited by the physical things we do. However, we have been adding outreach services. As I mentioned, our show vans now are going out into the various communities, especially those with high needs, to really try to provide services there and where appropriate or necessary, getting them connected to services, but starting the engagement process and screening processes there to provide those services in the neighborhoods, in the communities that have a much higher need. And also the addition of our tele mental health services has also provided a lot more access to these particular neighborhoods that don't have, such as physical clinics or programs in their neighborhoods. And we will continue to try to to market and advertise those to make those easily available.
Okay. And then the final, I guess, portion of my, actually two more related questions is about what I was talking about with the low reimbursement rates. Because, you know, something that I've seen that was done on the community level was there was a group of providers that were part of an IPA that went to a health insurance company because they had so many people in their network. And they actually went to the health insurance company and said, we want to negotiate rates and we're going to bring you X number of patients and all this. And so they were able to actually negotiate better rates for their group of providers. And so, you know, given that the reimbursement rates are so low with the city's employee insurance provider, I just wanted to know, you know, is there something that H&H or DOHMH can do, or the city can do to negotiate the better rates? And is that something that's on your radar? Is there a way that we can also help, you know, to push that?
So while we do not administer the H&H health employees, that's really more of the Office of Labor Relations that can explain a lot more than that. We do focus with our partners, especially the state and the city and DOHMH, on really, and also our advocacy partners on trying to advocate for better rates through the state and the federal levels. We do work with many of our insurance managed care partners on rates and worked on partnerships with them as well. But we certainly, you know, look for advocacy from everyone to help us with getting better rates for our patients.
Okay, and if there are any ideas or things that, you know, because you guys are obviously on the ground and you understand and see very clearly how the rates are impacting, I would say, care. So if there are things that you feel like can be done, I would love to hear those suggestions. And I just saw Dr. Lynn Walton unmute herself, so go ahead. Sorry, I don't know if you wanted to say something, but
No, I just had my phone going off. Sorry about that.
Oh, okay. Sorry about that.
We're
Okay,
happy to share. We can certainly share more with you.
Yes. Okay, that would be great. And then also in terms of what I mentioned earlier in my opening statement regarding the R designation, you know, it seems to be that that's sort of one of the, perhaps, I don't want to say barriers because I know there are reasons for it, but it seems to, you know, the higher licensing requirements. And so I'm just wondering how you think that is either negatively, positively impacting care, workforce issues, everything that we've been talking about.
I certainly think that you know, the higher restrictions, you know, can limit access or limit the ability for people to provide services. I think we have been very successful at having people both with the R or without the R provide services to our things. I think one of the things that has been helping is that we provide training through our mental health service corps, and looking now to expand that to a broader network within H&H, and how we are providing you with specialized training that if you wanted to go ahead for these certifications that you could, and encouraging people to be able to do that. But we certainly think that we would like, you know, to help with city and state advocacy on really looking at the issues of the specialized requirements.
Yeah, and if there's anything that we can do, because I know the licensing piece is important. So the thing I struggle with is how do we retain the dignity of the mental health providers while also making sure that we can have more folks in the pipeline and in the workforce so that we can provide services. So
yes,
yeah, there's always that balance. And just one final question before I hand it off to Chair Abreu is for the psych beds, because I know that you know, we lost a lot of the psychiatric beds because of the pandemic, and so how is it looking on the ground in terms of bringing those beds back up? Short term, long term, has it been going smoothly? What are some of the things you're seeing?
We have over, I don't remember the exact percent, but over 70% of our beds back online. We are in the process of bringing the rest of them. We have made a commitment to bring all of our previously licensed beds back online. And we have now a plan to bring those back online over the next period of time. The barrier generally is, as we say, workforce, and that's why we are looking at different models of care to be able to bring these lines back as quickly as possible.
Yeah, and I'm assuming that barrier of the workforce and other things are also just in general with the inpatient psychiatric care overall that's been difficult, correct?
Yes, same thing, yes.
Yeah, okay. And before I hand it off, I just want to recognize Councilmember Gennaro, who has joined us as well. Hi, Jim, it's good to see you. And I'm just going to hand it over now to Chair Abreu for some questions that he wanted to ask.
Thank you, Chair Lee. Thank you to everyone who's testifying. So the city witnessed a breakdown of communication and coordination surrounding provision of healthcare during the height of the pandemic. It is no secret that the former governor and mayor did not have an easy relationship. How has this relationship shifted under the current executives?
I can't comment a lot of specifics on previous administration, but for now, I think we have a great partnership between the city and the state. We all seem to be working together on a lot of the problems and projects that the city needs to help to improve access to mental health, especially post-pandemic. So I think we have a really great partnership and all moving forward in the same direction.
That's great. What does the current city communication with the state look like surrounding provision of mental health care? And how often does DOHMH H&H communicate with its colleagues in the state?
Well, I'll let Dr. McCraig comment a little bit more on DOHMH, but H&H has regular meetings and conversations with OMH, both the local field office as well as the state office and the commissioner directly. So we're very frequently in conversations. Actually, I have a weekly conversation with the field office myself on these issues, but we are in regular communication about all the programs.
Great. And generally, what more could the city be doing to advocate for better regulatory, funding, and political coordination with the city and state?
Well, I think we are doing a lot of that. As we said, there are a number of issues that we've outlined that we are working with city, state, and our advocacy partners with the legislation and the federal government to try to help improve and reduce barrier regulations. So the continued support and advocacy for these things, I think, would really help improve people's ability to access care and our ability to provide that care.
As we know, just recently the state passed its new budget. Can you please describe the city's understanding of the investments made in mental health care, and were they sufficient, or were you hoping for more substantial investments?
Sure. I can let Dr. Walton talk a little bit about that because she has been very active, involved in a lot of that part of it.
Yeah, I'm happy to. I think it's safe to say that the state and city are making strong investments. The city is still working out their own budget, so we're waiting anxiously and excitedly for that, as well as the city has organized with the state, and I'll turn it over to Dr. McCraig in 2 seconds, a discussion around the opioid settlement, and I know that that's happening as well, and DOHMH reaches out to us all the time for what are our treatment needs, what are our goals, and I'll turn it over to him for a lot more.
Yeah, so we're actually very pleased to see the additional investments in the state budget for mental health and substance use, or mental health and health care needs. We're always welcome additional funding for this critical work. The state has made important investments in supportive housing, which is a key key work of the Department of Health and the city more broadly. I think we always welcome additional state support, and we'll continue to evaluate the impacts of the state budget. I mean, it's relatively new, so we're still pouring through it, but we're actually very happy with the investments that the state has put into the budget around health and mental health.
Are there specific areas where you'd like to see more substantial investments?
I think I can get back to you on kind of specifics on some ideas, but I think kind of more broadly, we're pleased with the budget.
Okay, no problem. And Chair Lee and myself will be in touch with the admin on those issues. So
sure.
Are there areas where the city should continue its advocacy even now that budget season is over? I guess this may be an extension of the previous question.
I mean, I think that, as I mentioned before, I think the continued advocacy is, along with the state in trying to help reduce some of the regulatory barriers and making some of them permanent so that we are able to, during COVID, this really, the elimination of some of these regulatory issues allowed us to reach a lot more New Yorkers and have it much more easily in care. So continued work on those kind of things that make access easier and reduce the regulations that make it hard to deliver care.
Makes sense, Dr. Barron. And my last question is, I guess there's a few questions within this. Are there any challenges you anticipate when COVID emergency orders expire in relation to providing services or overcoming staff shortages?
I think many of them, this is a great idea of collaboration. The state, who does control a lot of the regulations, are in agreement with us. We've really provided, along with some of our other New York systems, feedback, and through Greater New York and other advocacy agencies, we've really provided a lot of input to them of what worked and what was really important to do that. And they have really agreed pretty much in general with us about what it's done. So they are working with those that need legislation. They've already made a number of changes of what's in their control so that we are able to do that. Yeah.
Okay, and so what measures are you taking to reduce the consequences of expiring emergency orders?
A lot of advocacy and conversation and collaboration with the state. Yeah.
Okay.
So that they know that our timeline is very definitive.
Okay. All right. No further questions, Chair Lee.
Thank you.
I could just add one comment. I think one example I can think of just immediately off the top of my head of what you're saying, and correct me if I'm wrong, is that, for example, telehealth, usually, and just from an outpatient clinic perspective, usually you have to go through an entire process to be able to offer telehealth, but obviously that was sort of went out the window and it was fast tracked during COVID. And one thing I think that the state did that was really smart was actually allowing for clinics to then have that window of opportunity to say, we're going to make it easier for you guys to provide this service permanently. And I think that is one example of how you can continue that access of care even post-pandemic. And so I think if we can continue to try to push the things that work well and things that we've seen through the pandemic that seem to have worked well, where we can have more of that reach, would be great. So whatever we can do, if there are other ideas like that from your perspective, from DOHMH's side, as well as H&H, if you could just let us know as well.
Definitely, thank you.
Yeah. Okay. And then I think we'll turn it back over to our moderator, because I believe, I don't know if any of the council members or fellow colleagues have any questions, but sorry not to take away from your role.
No problem. Thank you, Chair Lee, and thank you, Chair Abreu. I will now call on other council members to ask their questions in the order they have used the Zoom raise hand function. Council members do have 3 minutes for questions, and if you would like to ask a question and you have not yet used the Zoom raise hand function, please raise it now, and please begin your questions once I have called on you. Seeing no questions, we can now move to public testimony. I'd like to remind everyone that unlike our typical council hearings, we will be calling on individuals one by one to testify. Each panelist will be given 2 minutes to speak. Please begin once the sergeant has started the timer. Council members who have questions for a particular panelist should use the Zoom raise hand function, and I will call on you after the panelist has completed their testimony. For panelists, once your name is called and a member of our staff unmutes you, the sergeant at arms will give you the go-ahead to begin and set the timer. Please wait for the sergeant to announce that you may begin before delivering your testimony. I would like to now welcome Allison Burke to testify. After Allison Burke, I will be calling on Eileen Mayer and then Dr. Ruth Gerson. Allison, you can go ahead when the sergeant's call time.
Starting time. Allison, you're still on mute.
My goodness, I haven't been doing this long enough. It's been 2 years of virtual meetings. Apologies. Good morning, Chairs Lee and Abreu, and other council members. In the interest of time, and sorry for the technical blip in the beginning. My name's Allison Burke. I'm a vice president at Greater New York Hospital Association. I'm its point person on behavioral health issues. And thanks so much for holding this really important hearing today. I'm going to not repeat a lot of things because Health and Hospitals and Dr. Barron and Lynn Walton are both members and provide a lot of inputs and collaboration on all of the issues that you've all raised today. I'm just going to focus for a moment on the workforce issue. It's been obviously a very challenging 2 years for hospitals. The pandemic magnified, obviously, the need, the really important need for robust behavioral health services in New York City. Now, some of the challenges predate the pandemic, but obviously it's just been significantly worsened. This year's New York State budget and New York City investments in behavioral health are very much welcome, as other witnesses have testified. We think that's really the strongest way right now to address immediate pressures on access, and increases, cost of living increases for retaining qualified mental health and substance use workforce individuals, investments in rates. Chair Lee, you mentioned the woefully inadequate rates. And we think this is going to help in short order to strengthen and maintain what we have now. And we did hear a bit about some of the flexibilities, and we really appreciated them and are in regular conversation with our colleagues at the state to keep the aspects of the emergency flexibilities that really worked for the system, that moved the system where we were trying to get before the pandemic, and really have now got demonstrated experience that the telehealth really works. We were able to engage
Time expired.
New people accessing care and maintain vital services. My time is up, so apologies.
Oh, no, but if you wanted to close out, go ahead.
Well, I was just going to say, just in an effort to speak a little bit on the coordination, we are really working with all of our partners at the city and the state level. And just as an example, with the opioid pandemic, we have a program coming up the first week of May with our federal partners on some of the medications for opioid use disorders that really, the flexibilities were astronomical and really helped a lot of individuals with opioid use disorder. And we hope to have those remain in place. So there's, at all levels, a lot of unprecedented collaboration and communication going on.
Thank you, Allison.
Any questions?
I would like to now invite any questions from council members if we have any. Seeing none, I would like to now invite Eileen Mayer to testify, followed by Dr. Ruth Gerson, and then Karen Remy. Eileen, you can go ahead when the sergeant's call time.
Starting time. Eileen, you're unmuted, but we don't hear anything.
Hear me now? I apologize.
Yes, now you're good.
Can you hear me now?
Yes, we can.
Okay. Hi, my name is Eileen Marr. I am a community activist and civil rights leader from Bocal, New York. I am also a woman who is formerly incarcerated, a criminalized survivor of domestic violence. Since my teenage years, I have suffered with mental illness, a self-harming diagnosis, and an addiction to opiate pills for which I have had periodic active periods of. With that out of the way, I'm here to discuss the mental illness to incarceration pipeline in New York. I've been blessed with supportive family and friends, as well as an impeccable combination of mental health services. And yes, I am on a Medicaid-backed healthcare plan, but many are not. Millions are not. This includes individuals who were and are suffering from addiction, physical, and mental illnesses. As an incarcerated woman, I witnessed and befriended individuals who were behind those bars simply because they had lacked the appropriate mental and physical health care. This included individuals with substance diagnosis, severe physical ailments, self-harming diagnosis, and developmental disorders. Had they had access and outreach to and received even a minute amount of healthcare services, they would not have been incarcerated. And jail and prison are not and never will be the place to treat and maintain the mentally ill. It only exacerbates the illnesses, as it did with my own. I relapsed into self-harming and abusing opiate pills, as well as the PTSD and anxiety disorders that are part and parcel with the American carceral system. Additionally, over the past 2 years and entering into the third, I have seen unhoused mentally ill, addiction diagnosed, and physically ill individuals residing, so to speak, on the street, unhoused. People that I've not seen since the 90s and the pre-Giuliani disaster. People from the so-called Old Times Square Hell's Kitchen and the Lower East Side. When I asked an old acquaintance where he had been, he answered, the island, the boat, up north, Kirby.
Time expired.
I just have a minute left. While the bail and discovery, halting solitary confinement, and parole laws that I myself have advocated and fought for are changed and a godsend and should in no way be rolled back, there should have been a mass infusion of coinciding mental health and substance addiction services. There has not. Yes, there has been an unprecedented pandemic that monopolized most of the healthcare professionals and service providers. However, that did not mean these individuals should have been left behind, as they have been. Outreach for mentally ill and addicted should not have all but been abandoned. Coupled with a broken, inadequately trained, classist, and racist NYPD is a recipe not only for disaster, but a means to fill our jails and prisons to capacity, primarily with individuals who should not only not be there, but will not receive any true and appropriate individualized care. Translation: the mental health and health providers in our carceral system, some partnered with health and hospitals, are bug. Not everyone has the family and friends who are eternally supportive like I do, even when I fall. Not everyone understands how to or where to receive services. And not everyone is as demanding and knowledgeable as to what services I need and how to get them when I need to and choose to. Narcan and fentanyl test kits are a blessing for all of us, but it isn't just Narcan and flyers for the local methadone program. One of my oldest friends, a New Yorker, died of a substance overdose. He self-medicated with heroin for over 30 years as a result of PTSD from sexual abuse, prison, and he was clinically depressed. Yes, he tried to secure a program that worked for him in New York time and time again, but most were inadequate and simply handed him some methadone and sent him on his way. He was, as many others, needed services for individuals with a dual diagnosis, triple, but that's not a thing. However, the programs that would have provided this are few and far between. Had there been legal open consumption sites, and he and thousands of others like him may have been saved. Not only would they be able to consume in a legal, safe place, but there would have been access to appropriate harm reduction programs. With all of this said, I urge the city to provide a massive infusion of mental health, addiction, health services, and outreach. There are people willing to provide outreach despite the highs and lows of COVID. In conclusion, I urge health and hospitals to seek their own humanity and to help these people before it's too late, before we have another jam-packed Rikers Island or another situation like the closing of Willowbrook. Thank you, and thank you for your time.
Thank you, Eileen. I do see that Councilmember Williams has her hand raised, and we can turn to you for questions.
Starting time.
Thank you. I know that the administration, I believe, is topped off. So wondering if you have information on how the city is addressing the phenomenon of the corrections department also bearing the brunt of the lack of inpatient hospital beds. And if you don't have the answer, or if you do have the answer, I would like for us as a committee to also ask the administration next that don't believe I heard too many questions on the lack of hospital beds for patients who really need inpatient care.
Okay, I see that Dr. Barron is still on and he unmuted himself. So, so Councilmember Williams, I think he'll probably be able to answer or try to answer parts of your question.
I will actually probably have to get back to you.
Okay. But just, Eileen, I don't know if you can hear me, but I just wanted to personally say thank you for your testimony and sharing that, because I think you highlight so many of the issues that we're seeing. And that's one of my pet peeves, as well as, you know, again, as you said, thankfully you do have the Medicaid coverage, but there's so many others that don't have the insurance and don't get the services that they need. And oftentimes, I just said this on the panel I was on yesterday, is that I do think that public safety is downstream to mental health, meaning if we're talking about mental health care overall, I do think that we will see a betterment in the, public safety that we're seeing. And it's, there are parts of it that are related, but other parts that are not. And so how do we make sure that we're not using Rikers in the prison system as a way to care for the mentally ill, right? So I just wanted to thank you for that. Oh, sorry, I think you're muted, but we have your testimony. I'll definitely try to see if we can reach out afterwards. Thank you.
Thank you. I do see that Councilmember Palladino has her hand raised. Councilmember, you can go ahead when the sergeant's call time.
Starting time.
I want to echo, good afternoon, everybody. I want to echo what Linda did say, and I want to thank the panel for today's discussion. But before I run out of time, Eileen, you are extremely brave, and it's encouraged me tremendous to say what I'm about to say. I, like people who have gone through the system and have suffered terribly through self-medication and going to Rikers and spending some time there. But here it is, quite frankly, to have 50 psychiatric beds per 100,000 people is absolutely ludicrous. That's part of our problem. Now, in the year 2000, we had 6,000 some odd beds, inpatient psychiatric beds. By 2018, that number dropped to 5,400. This is a city that has over 8 million people living in it. We have all talked about the size of the increase in depression and anxiety and mental health. We have facilities that need to be reopened. We have facilities that need to be occupied and spend the money the proper way. There are 20,000 empty beds waiting in these different state hospitals and city-run hospitals that can be reopened and funds allocated the proper way. These people do not belong in prison. These people belong in the proper health care, with the proper health care. And I know, dealing with the nonprofits that I've seen come through this door, there is one nonprofit that hits me really, really hard. And I would like everybody to start to consider this. TSI, they're called, Transitioning in New York. And Linda, I'm going to talk to you about this organization. They've been around since the 1970s. And the people that I am referring to, Eileen, also have been through the 70s, the 80s, and I understand exactly what you're going through. And I think there are other ways to do this. And I'd like to see us put our city-funded and our state-funded dollars, because according to Hochul and what she has put aside is somewhere in the vicinity of $550 million. Okay, it says it right here on the papers that were given out to us today. I've highlighted them, but because I only get 2 minutes and my 2 minutes is up, I would like us all to take a look at this. And I believe it's on page 3 and page 4 and page 5 and page 6. So if everybody would take a look, I'd appreciate that very much. We've got to get these people the help they deserve and the help that they need. Thank you, Eileen. Thank you, Linda. Thank you, everybody, for participating today. And thank you for having me.
Thank you, Councilmember Palladino. Seeing no additional hands raised and no additional questions, we would like to now invite testimony from Dr. Ruth Gerson, followed by Karen Remy, and then Brett Waters. Dr. Ruth Gerson, you can go ahead when the sergeants call time.
Starting time.
Thank you. Can you guys hear me okay? It's working? Okay. Well, thank you so much for having me. As Senior Vice President for Mental Health Services at the New York Foundling, I am so honored to have this opportunity to testify before these two committees. The Foundling has extensive experience in working with both the state and the city mental health agencies, and we have been a leader in providing evidence-based treatments that work for youth and families. Also, I have to apologize for my voice. I have COVID, so I don't sound very good. I apologize if I'm unclear. When children and youth are experiencing mental health symptoms, that impact escalates quickly. Children miss school, parents miss work, entire families are stressed, and this worsens the child's symptoms, leading to a rapid and spiraling crisis. The solution is twofold. First is prevention, second is treatment. Advances in science have shown us that risk for mental illness and substance use disorders is laid down in early childhood, rooted in adversity and trauma. Prevention programs that screen for, prevent, and treat early adversity, trauma, and risk factors have tremendous impact on a child and family's trajectory. These programs should be embedded in prenatal and primary care, pediatrics, foster care, and schools. Our treatment services should also be embedded in family and community and should include effective, evidence-based, and trauma-informed care. The Foundling is one of the few providers of family-based, evidence-based mental health treatments for children and families, and this is the kind of treatment that families want. In our family-based treatment programs, more than 75% of families complete treatment successfully, compared to the city's largely individual therapy-oriented programs where up to 90% of trauma-exposed youth terminate treatment early. So how do we achieve broader access to family-based and evidence-based treatment? First, as Chair Lee said in her opening remarks, clinic reimbursement is just not sufficient to support this kind of work, and nor do current or proposed increased rates for CFTSS and HCBS services. Clinic-based CFTSS and HCBS services are further hindered by different eligibility and enrollment processes, different systems for documentation, requirements for duplicative treatment planning, individual rather than family-based care management, divisions in the adult and child systems that prevent family-based care, and lack of sufficient workforce. Second, we need investments in intensive and specialized services for high acuity youth, but these should also be evidence-based programs that let kids stay in their home and schools, such as the Foundling's Partnership to Improve Community Health Outcomes, or PICO program, which is an evidence-based treatment program that reduces ER visits and hospitalizations to save more than $12 million in insurance costs and taxpayer dollars over the life of the program. And third, as many have said, so I won't repeat it, we need investment in workforce with salaries, COLA increases, training support that allow clinicians to build careers in the public sector rather than being forced to choose between mission-driven work and supporting their families and having to flee to better paid private practice jobs. Thank you so much for your attention to this important topic. I'll happily answer any questions. Thank you for this opportunity to speak.
Thank you, Dr. Gerson. Seeing no hands raised, I would like to now move on to calling on Karen Remy to testify, followed by Brett Waters and then Lilia Burns. Karen, you can go ahead when the sergeant's call time.
Starting time.
My name is Karen Remy, and I am the Clinical and Community Services Director at Greenwich House. Thank you to Chair Lee, Chair Abreu, and the fellow City Council members for this opportunity to testify. Since Greenwich House was founded in 1902, we have been committed to addressing the needs of children, families, older adults, and individuals working to overcome life's challenges through arts, education, senior services, and health services. In 1969, when we first opened our methadone maintenance program, it was one of the first programs of its kind in New York City. Today, we effectively treat 1,000 opioid-dependent individuals every year. Greenwich House MMTP provides harm reduction and recovery services, which are designed to meet the needs of the individual by customizing care to their specific circumstance. Our services enhance quality of life, diminish the symptoms of opioid dependence and withdrawal, foster connection with the community, and save lives by helping to prevent overdoses. MMTP provides the highest quality of care to opioid-dependent individuals and extends our treatment services to families who are impacted by substance abuse. Greenwich House applauds this bill to create the Nightlife Opioid Antagonist Program to help prevent opioid overdoses in nightlife establishments and urges this council to adopt it. Overdoses have risen dramatically over the course of the pandemic. You know that already, I'll skip that. After doing this work in the community for 50 years, we know that harm reduction tactics are our best solution to addressing the tragic trend by increasing access to Narcan kits and training to administer it. This bill would undoubtedly save the lives of recreational drug users and nightclub settings that tend to attract younger demographics. But New Yorkers of all ages and backgrounds are being impacted by rising overdose rates and deaths. Additional investments in harm reduction interventions in a range of settings, including other businesses and in residential settings, would go a long way. I thank you for this opportunity to testify. And I'm sorry about that. I've been talking all day.
Thank you, Karen. Seeing no hands. Go ahead.
No, I was just going to say, good news is that the council staff read every single word of all your testimonies, which is good.
Thank you, Karen. Seeing no hands raised, we will now move to testimony from Brett Waters, followed by Lilia Burns, and then Leisha Luokai. Brett, you can go ahead when the sergeant's call time.
Starting time.
Good afternoon, council members. Thank you so much for the opportunity today. I'll try to keep this pretty brief. This is a bit of a longer term, but also I think very significant issue for the city to engage in, really starting now, given the enormous challenges that we hear financially with current access to mental health care and the financial burden that it's placed on the nation, the state, the city, and that costs and spending keep going up, but outcomes are just not getting any better. I mean, we really are going to need drastic changes to the system of care. And so that's why I wanted to flag there is a bill that my organization, Reason for Hope, is running in Connecticut right now to fund an expanded access program for MDMA and psilocybin-assisted therapy. It would create a pool of funding to incentivize providers to be able to go through the administrative burdens of setting up the expanded access programs, with the knowledge that this treatment that would be very expensive and not covered by insurance at first is going to have patients who will actually be able to pay for it. And qualifying patients would be those from underserved communities. And in Connecticut, it's also veterans, first responders, and frontline healthcare workers. I think that New York should be doing something similar to also provide the funding needed to start training practitioners, particularly in underserved communities. This is a very new form of mental health care that's coming, that's going to require new specialized training. It's going to be a very complex process involving the federal, state, and local governments to get this implemented into the healthcare system. But we've been working closely with the federal government to start on this process. There should be some announcements coming soon. And there is a bill that Assemblyman Burke is running in New York State. I've been working with Assemblyman Gottfried as well. And I think that in the couple months we have left, we can pass a bill similar to what we're doing in Connecticut, but we'd love to have the city, speak up to make this happen in the couple months we have remaining. So happy to answer any questions.
Can you actually send more information on that? Is that okay if you could send
Yeah,
that?
happy to. I sent some information to Sarah and Christy yesterday, and I'll circulate it.
Awesome. Thank you.
Thank you, Brett. Seeing no additional questions at this time, we will be moving to testimony from Lilia Burns, followed by Leisha Luokai. Lilia, you can go ahead when the sergeant's call time.
Starting time.
Hi, good morning. My name is Lilia Burns. I am the Assistant Executive Director of Behavioral Health Services at Hamilton Madison House. Thank you all for this opportunity to testify. Hamilton Madison House is a nonprofit settlement house located in the Lower East Side, established in 1898. We are also one of the largest outpatient behavioral health providers for Asian Americans on the East Coast. Currently, we operate 5 mental health clinics, a personalized recovery-oriented services program, an outpatient substance recovery program, a supportive housing program for individuals with severe mental illness needs. Our staff are primarily bilingual, and we are able to provide services in Cantonese and Mandarin Chinese, Korean, Japanese, Cambodian, and Vietnamese. The large majority of our patients we serve are first-generation immigrants of low-income status, and many are receiving therapy for the first time. For Asian Americans, access to behavioral health care is already challenged by a variety of factors, from lower utilization rates because of cultural stigma to a lack of funding for culturally and linguistically competent providers and agencies. As hate crimes targeting Asian Americans continue to rise along with the effects of COVID-19, we have seen a sharp rise of referrals with symptoms of deep fear, anxiety, depression, and other mental illnesses. In the last 2 years, with the unprecedented need for mental health services in our community, Hamilton-Madison experienced tremendous hardship in being able to provide and keep up with the demand. Not unlike other social services agencies, our workforce has been taxed to the brink. However, we experienced even more hardship in attracting bilingual staff due to limitations of funding streams that would allow us to be competitive, as well as offset visa sponsorships to attract international clinicians. Despite those challenges, we did not turn away from our community members, but instead we increased our contacts to provide counseling, crisis therapy, and added frequent check-ins to provide case management, as well as concrete services via telehealth, telephonic, and in-person services. To respond to the urgent call to deliver these mental health services to the community, we must prioritize funding and invest in Asian-led and Asian-serving organizations. Hamilton-Madison House is one of the few agencies who are able to culturally and linguistically competently serve the community. However, we need to really invest, recruit, and retain qualified staff. There needs to be strategy to be put into place to inform those going to social services that they matter and that serving their community is more than just personally rewarding, where they can also earn a living wage, which allows them to pay off educational loans and invest in their own future. Organizations like ours are mission-driven in providing much-needed mental health services to the community, require consistent support and funding in order to attract bilingual speaking staff. As experts on the ground leading the charge in providing culturally competent services, without continued support and funding to the mental health sector, it will only lead to more and deeper crises. We strongly urge the community on mental health, disabilities, and addiction to address these issues and concerns by allocating appropriate funding streams to increase mental health services and services to people living with severe mental illness in the Asian American community. Thank you so much.
Thank you, Lilia. I do see that Councilmember Gutierrez has her hand raised, and we can move to you for questioning. Councilmember?
Starting time.
Hi, thank you, Lilia, so much for your testimony. I love hearing all of your points about not just language access, but cultural competency. As a caregiver of a 71-year-old, I've discovered that more and more throughout her health journey, it has become increasingly important to not just speak the language technically, but to also really come from a place of empathy and like how you highlighted cultural competency. I would love to learn a little bit more about, and maybe this is not the space, but I do just appreciate everything you said. I'd like to learn a little bit more about, sorry, it's my crying baby. I would like to learn a little bit more about what the kind of average interaction is with one of your patients. What are some of the issues that you think were the most paramount, especially during the pandemic? And if you wanted to highlight how you were able to switch to, I guess, remote care for your patients during the pandemic, and what were those challenges like? Thank you.
I think Lilia needs to be unmuted. She can answer.
Thank you. Great. Thank you for that question. So during the pandemic, one of our challenges has been to be able to, well, many of our clients, they prefer telephone instead of telemental health platforms, because many of them are not able to, one, navigate the platforms, but also they have limited funds to be able to access these devices. So telephonic therapy services have been the preferred method during the pandemic. I think many of our community members experience deep fear, not only because of the stigma to access care, but also due to COVID, they are deeply afraid to go out just to get basic needs such as food and to get much needed items. And so many of our clients are afraid to come out of their homes. They have difficulty assisting their family members who are elderly. And so our challenge had been, one, providing the devices to access to care, but also be able to reach them.
Thank you, Lily. I'd love to connect. I know your time is up, but I'd love to connect if we can, if the committee staff can help. Because I know that
absolutely
likely serving any folks in my district, so I appreciate it. Thank you. Thank you, chairs.
Thank you.
Councilmember Gutierrez, I will personally attest Hamilton Madison is an awesome organization. They do such amazing work. So
thank you, Chair Lee. Thank you.
Thank you. We will now turn to testimony from Lisha Luokai. Lisha, you can go ahead when the sergeant's call time.
Starting time.
Can you guys hear me? Okay, very good. I want to thank Chairs Lee, Abro, and council members of both committees for holding this hearing and giving the Asian American Federation the opportunity to testify on the mental health needs of our community and our mental health service providers. I'm Lisha Lukai, Advocacy Coordinator at AAF, where we proudly represent the collective voice of more than 70 member nonprofits serving 1.5 million Asian New Yorkers. This conversation on mental health is coming at a critical time. Recent surveys we've done with our small businesses communities and our senior serving organizations and their clients highlight the dramatic needs for mental health care in our community. Our survey report we published late last year about Asian small business owners showed that over 60% of respondents said they were worried about anti-Asian bias and hate crimes for the safety of themselves, their staff, and their business establishment. More than 80% of respondents in a survey of seniors who use services from our Seniors Working Group Coalition reported that mental health and social isolation were either important or very important. And our mental health providers are stretched thin to meet the demand. Our member organizations have continuously demonstrated that they're the experts in providing the services most needed, and we're making the tangible progress towards addressing mental health accessibility in our communities, including the first ever Asian mental health directory that went live on Asian American Federation website, a searchable database of providers providing mental health services in 17 Asian languages across all 5 boroughs. Mental health service delivery in the city's most diverse community is notoriously difficult. More than 20 Asian ethnic groups are represented within our community, speaking dozens of languages. The shortage of linguistically and culturally competent mental health practitioners, which is particularly serious in areas of specialty, highlights the urgency to address these gaps and ensure that our community has equal access to mental health services that cater to their unique needs. The city and state must do a better job of aligning funding with the intricacies of providing mental health and broader service support to our most vulnerable communities.
Time expired.
One of our member organizations doing incredible work to provide mental health services in our community is Hamilton Madison House, who just spoke before me. AAF's recommendations are to provide increased consistent investment in Asian mental health organizations, to build bilingual and culturally competent staff capacity and expertise to address the increased needs of clients with severe mental illnesses, as well as implement preventive measures where possible. Develop the capacity of Asian serving community-based organizations to identify mental health needs and provide non-clinical interventions, as well as develop a workforce initiative that creates a pipeline of Asian mental health professionals skilled in bilingual and culturally competent mental health care. Our CBOs are doing everything they can to address the mental health crisis that afflicts the Asian American community in our city. However, they cannot succeed without help from the council, and the challenges they face must be top of mind as you consider the state of the city's mental health service provision efforts. We at AAF thank you for allowing us to testify and look forward to working with you all to make sure our communities get the mental health support they deserve.
Thank you. Seeing no questions at this time, we'll call on anyone we may have inadvertently missed. Please raise your hands if you have signed up to testify and haven't been called. Seeing no hands raised, Chair Lee, Chair Abreu, do you have any other questions you would like to ask?
I do not.
No further questions. Just wanted to thank especially the public for their testimonies today. And of course for DOHMH and Health and Hospitals for being here. Because I think, as it was mentioned several times, I think we have such a great opportunity to make some impactful changes across the city when it comes to mental health services. So I look forward to working with everyone.
Likewise, I'm very grateful to everyone who testified. Thank you again, Chair Lee, and to the committee, council, and staff for all your incredible hard work. Now let's get to work and addressing these critical issues.
Oh wait, J3, you're muted.
Hey, we all make that error at some point. I'm saying with that, we'll turn it to you, Chair Lee, to close out the hearing.
Sure. Does that require me to gavel? I have to close it out. Okay. Thank you again so much. Very complicated issue, city and state, but I look forward to working with everyone together. So thank you. And with that, I will close out the hearing.